Okay, so I'm going to get started on my lecture. This is titled The Heat Waves to Come. I'll get right into it. Thanks to Doctors Daniel, Dukas, and Silverberg for their help in setting this up. So, quick outline here, case presentation, climate change update, heat stroke in the ED, public health interventions, finishing case, and conclusion. So let's start with a case. It's summertime, real swelterer. The AC just is not keeping up. You're in CCT and your scrubs are soaked through and they smell terrible. You hear the note phone ring. They say 41-year-old female found down, ETA is 5 minutes. EMS shows up. The patient is already intubated. They're bagging the 16 gauge IV in the arm. They say, she was found down. Bystanders called the ambulance. No blood pressure was able to be gotten in the field. The heart rate's 150. Her temp is 41 degrees Celsius. And her O2 sat on room air before they intubated her was 89%. She's got ice packs all over her body. You get the nurse to do a temp. And again, rectally, it's still 41 degrees Celsius. You're starting to do your assessment. The ABCs are intact. She looks diaphoretic. She's obviously obtunded and intubated. You can hear breath sounds, mechanical, but there's no real rails or wheezes. When you're doing your exam, though, she starts going into diffuse tonic-clonic seizure activity. You ask the nurse for 2 milligrams of lorazepam stat, but what is going on here? What is your differential? Like, let's start sounding off in the chat. Like, tell me, what are you guys thinking here with this presentation? Seizure, sure, but what's causing the seizure? Heat stroke, beautiful. CNS infection, absolutely. Stroke, possible. Serotonin syndrome, excellent. Thank you, Dr. Graff. Thyroid storm, alcohol, all of these are things you have to keep in your mind. But ultimately, this case is an actual case report from 2016 of heat stroke. So, briefly, let's talk about climate change. Climate change is bad. It's going to get worse. This is from a State of the Climate report from earlier this month. We are on the brink of an irreversible climate disaster. This is a global emergency beyond any doubt. Much of the very fabric of life on Earth is imperiled. So, pretty sunny disposition. Uh, Things are going bad. The carbon sinks that help reduce the amount of carbon in the atmosphere are failing, which is an additional thing that our climate models were not predicting. We're already seeing severe weather events more frequently and more severe than prior. These are images from Helene and Milton from this year. And we're seeing this in fires and heat waves as well. July 22nd, 2024 was the hottest day on planet Earth since recording, and it's only going to get worse. These are pictures of simultaneous fires in the Amazon rainforest in summer this year, and this is from the Canadian wildfires last year. And so, why do we have to care about this as doctors? Because it's going to affect us, and we're going to see it in our EDs. There is heat waves in the summer, usually in July, and we've been seeing increased mortality and morbidity from them all across the world. So let's talk about heat stroke and how we see it in the ED. So definitionally, heat stroke is a temperature above 40 degrees Celsius or 104 Fahrenheit with altered mental status. You can have organ failure, but it is not required for the diagnosis. So there are two types of heat stroke. There's going to be exertional, where you have somebody like a marathon runner, for example, who towards the end just starts feeling really bad and passes out. So that's going to be usually younger, athletic people, or at least middle age, versus non-exertional, where you have usually older or much younger people who, because they have difficulty regulating their own temperature, end up having elevated temperatures leading to altered mental status. Basically, the pathophys of this is that increased temperature leads to cytotoxicity and increased permeability of membranes, leading to a diffuse inflammatory response. And that leads to diffuse coagulation, basically micro and eventually macro ischemia, leading to liver failure, renal failure, pulmonary edema, rhabdomyolysis, DIC, all very bad things. This has significant morbidity and mortality, up to 50% mortality in elderly in some studies, and then also 25% mortality regardless of treatment in pediatric patients. And just to define a heat wave, you don't need a heat wave to see heat stroke, but you're much more likely to see it during a heat wave. Heat wave is 2 or more days with temperatures at or above the 99th percentile for a certain area. So our differential, like you were seeing in the chat, it's going to be broad. You've got infectious ones, of course, with an elevated temperature. You might be thinking sepsis, meningitis, with a sudden collapse, maybe some sort of embolism. For neuro, you could have a stroke with this kind of altered mental status, but the fever isn't really sticking with that. But status epilepticus, with the amount of rhabdo, muscle breakdown, you could potentially see a fever there as well. Endocrine, absolutely thyroid storm, maybe DKA from an infection as well. Toxic is going to be something you have to keep in mind. MDMA, PCP, and cocaine all induce hyperthermia on their own and can lead to heat stroke. Serotonin syndrome could be an issue. This could be a suicide attempt of some sort. Neuroleptic malignant syndrome could lead to a fever and hyperthermia separately due to the muscle breakdown. Anticholinergic syndrome or strychnine poisoning. This is just a very long list of things that could be going on tox-wise. And then ONC, somebody who has AML, maybe a blast crisis in CML, or tumor lysis syndrome if they've been started on chemotherapy recently. But ultimately, take-home point for the differential. If you're worried about the heat stroke based on the history, manage it as a heat stroke. So how do I do that? How do I manage a heat stroke? You cool it down. Rapid cooling within 30 minutes is associated with decreased mortality in heat stroke patients from 50% to about 5%. So how do we do that? And there's this method called TACO. What's TACO and why is that important to know as an emergency department doctor? So first, there is this big meta-analysis by Duma out of 2020. They looked at 63 studies, most of them randomized clinical trials, and they compared techniques of cooling. And they compared it by rate, and they tried to compare it by morbidity and mortality. As you can see by this graph here, it looks like the immersion techniques are much better, but those standard deviations are really wide. They said that there's no real difference between the different immersion techniques. But as long as you're putting this person in fluid between 1 degree Celsius and 17 degrees Celsius for a goal temperature of 38 to 39.4 degrees Celsius, you're going to have optimal cooling. However, they didn't differentiate well between the different methods of immersion. Do you put them in a tarp? Do you put them in a bath? They didn't correlate or didn't have the data to do that kind of breakdown. On top of that, they didn't really have, sorry, didn't mean to go forward. They didn't really have enough data to actually break down morbidity and mortality either. The data on this is very poor due to the acute nature of the condition. So I mentioned taco earlier. Is it a delicious lunchtime or dinner snack or breakfast if you're adventurous? No, it stands for TARP assisted cooling and oscillation. Basically, it's a way to immerse a patient in cool fluid without necessarily having a big bathtub to stick them in. You put the patient in a tarp, you cover them in ice and water, and then you shake it. There's a great video, if you look it up online, of this EMS educator doing this for an exertional heat stroke patient. Basically, it guarantees that there is a diffuse amount of cool liquid to help with the dispersion of heat, and shaking it helps make that as optimal as possible. It's faster than getting a tub of water. It's more feasible for an emergency department. And you can use it while you're setting up an actual tub to put these patients into. In the ED, we use body bags. We don't necessarily have a tarp. We put the patient into a body bag, and then we fill it with ice and water. So going back to that study, like I said, the mortality wasn't consistent, as you see where I highlighted. Mortality ranged in these studies from 0% to 71.4%, huge and not very helpful. There was too much heterogeneity to perform subgroup analyses. So with that in mind, do we have any scoring to guide management here? Something to help us with dispo? Is a patient safe to go home? Should they be, admitted to the hospital? We do have a couple. There's another study that came out of Japan where they deal with exertional heat stroke in their primarily elderly population. They came up with a scoring system called JAM. It's sensitive for in-hospital mortality. Basically, the scoring system is physician suspicion. If their GCS is less than or equal to 14, if they have elevations in their bilirubin or their creatinine indicating liver and kidney failure, uh, and if they have four or more points on a DIC scale. Uh, Basically, this is sensitive for in-hospital mortality, but it's not sensitive at all for neurological recovery, organ failure, or length of stay in the hospital. Basically, I would say this is a tool for determining who, if they're not intubated, but they're still not really themselves, and they've got lab abnormalities, would benefit from staying in the hospital a bit longer. It's something you can use to maybe convince the admitting team that this is somebody worth watching. Now, you've got this case. The attending says, can you go put in some labs for this patient? What are you going to get? Main things I want to say is, very broad. You're going to have to get lactate, ABG, tropin, CK. You may want to get a dimer depending on the presentation and history. And you may want to also get cultures in LP if infectious etiologies are still on your differential. For imaging, I would absolutely want to get a CT head based on this altered mental status, and plus or minus a CT angio if you're concerned about a massive pulmonary embolism. In terms of meds, the main thing that studies have shown is to avoid antipyretics. Hyperthermia is not going to improve like a fever would to an antipyretic. It may, in fact, make the liver failure worse if you're giving it. So you want to avoid acetaminophen or salicylates in heat stroke. You also want to avoid pressors. This is a theoretical avoid, where some studies said that it could reduce the amount of heat transfer at the surface of the skin, but we don't have actual data to back that up. Benzos are helpful in terms of managing seizures, in terms of managing the muscle breakdown and then shaking that can occur. And IV fluids, plus or minus refrigeration, would be great. And if you're still concerned about infection, put in some antibiotics as well. For interventions, intubate, support if they're not protecting their airway, and then immersion therapy with taco or with a big tub. So, what are the wider societal interventions that are happening to sort of help with the oncoming increase expected of heat stroke? We've got cooling centers in New York City. So there's a website called New York City Cool Centers. It has a bunch of public cooling centers in their hours. You can, give it to patients in the ED if they're concerned about becoming too hot. There's also an NYC Parks site called Cool It, where it shows water features, canopies, forest cover in the city, and then categorizes neighborhood by heat vulnerability index, which is a public health measure of how likely morbidity and mortality is in a neighborhood based on its features, such as like amount of concrete. Our, Prospect Lefferts Gardens HVI is 4, which is the second worst, most likely for morbidity and mortality in the event of a heat wave. So we're in an area that is likely to see cases like this. But these are both great resources to share with your patients. So let's finish up this case. Basically, her seizure was ended by the benzo administration. Her blood pressure is okay at this point. You put her in the body bag, put in the ice and the water. You say, try to keep a goal temperature of 38. You make sure the nurses put in a continuous temperature probe into the rectum so you have central measurement during this therapy. Her labs are pretty bad. She has a pH of 7.1, platelets of 49,000, creatinine 1.5. She's in rhabdo. She's got a lactate. She's got transaminitis. Her tropin D dimer are high. You got a lot going wrong here. On POCUS, her FAST is negative. She has an intact ejection fraction in the heart, no abnormal movement abnormalities. She's got no B lines in the lungs. Her EKG is sinus tachy. There's non-specific ST changes. You're not concerned about an MI. Her CT head is negative. Her CT chest is negative. She goes up to the MICU after you put Foley in, give her antibiotics and a bolus, but she does well. Day 2, she wakes up, she's extubated. Day 3, she's been downgraded. Day 10, she's transferred to inpatient acute rehab. And by day 17, she's discharged home with a full neurologic recovery. So let's talk about take-home points. We're going to be expecting more and worse heat waves in the future, and our community is going to be affected by them. The definition of heat stroke is greater or equal to 40 degrees Celsius, 104 Fahrenheit with AMS. The goal for managing this is a rapid cool with taco for immersion therapy and as a bridge to being put into a tub. You want to have a goal of 38 to 39.4. There's a broad differential diagnosis here, so you want to make sure that you're looking for all of these other things that could be happening in addition to heat stroke. You can use the JAM score to help with who needs to be admitted and who can go home, and use the NYC Cool Options and Cool It sites to help inform the population about what resources are available outside of the ED for them to help avoid heat stroke. So, questions?